Human milk and commercial milk substitutes are not the same, and no artificial product can provide the complete nourishment and protection that breast milk affords to our newborns and our infants. Saying that breast is best really isn't a good option, a good thing to say, because if you say breast is best, then you really leave room for interpretation that commercial milk substitutes or formula may not be best, but it's next best, and that can be just as good. So, to help clear the issue, the American Academy of Pediatrics issued a position statement recommending that infants be exclusively breast milk fed for the first 6 months of newborn life and to continue breast milk feeding for the first year of life. Now, in that first year, they can, after the first 6 months, add complementary foods as appropriate. So you got to think about as the baby progresses in age, getting the finger foods and such. Remember that babies are going to have about 4 to 6 months of iron stored from what they laid down when they were in the uterus. If the infant is weaned from the mother before 12 months, so we take the breast milk away before 12 months, the recommendation is to give an iron-fortified breast milk substitute or formula to cover the iron deficit as opposed to giving regular milk. The United States has recognized the benefit of breastfeeding and has lent its support to creating health promotion practices and goals in conjunction with Healthy People 2020. The goal for Healthy People 2020 is to have breastfeeding initiated in at least 81% of births and to have at least 60% of those couplets still breastfeeding at 6 months. Initiation counts as when the baby is born, if even once during that hospital stay that baby went to the breast and fed, that counts as an initiation rate. It's not exclusive if they give the infant formula, but it is an initiation if it nurses even one time. The 60% goal is for the baby that initiates to be still breastfeeding at 6 months. It doesn't say exclusive, but it is to be still breastfeeding at 6 months. As of the last report for the 2020 goals, in 2011, the initiation rate for breastfeeding was at 79%. So we're not far off from it. And for the continuation rate at 6 months, the 2011 value is 49%. Again, not that far away from it. Interesting, demographically, statistics when they did the Healthy People evaluations and goals showed that women more likely to breastfeed are going to be those that are Caucasian, well educated, and over 30 years of age. When you're thinking about talking to a mom about choosing a feeding method for her baby, don't wait until she's in labor and try and talk to her about, does she want to breastfeed, formula feed, breast milk in a bottle feed. That's conversations that should be started in the prenatal period. On her very first intake visit, the question should be asked, do you have a preferred feeding method for your baby? Women should be given factual and supported information regarding breast milk feeding and how it differs from formula, and just why it is that the American Academy of Pediatrics has recommended breast milk feeding as the preferred feeding method. Even if the woman gets really good information, even if her provider starts it at day one in the office, She still has friends and families, acquaintances that, have gone through, having kids. They can influence her decisions. They can hinder her initiation of it, or even more the continuation of it. You got to think, if you've got somebody who's waffling over which way is it to go, it can be really easy at 2 o'clock in the morning to let somebody else get up and fix the baby a bottle and feed the baby, and then you can stay in bed. You don't have to worry about, how am I going to go to work, and am I going to be able to get my job done? I can't breastfeed because I'm working. It's easy to find reasons to not do it if you aren't 100% committed, and if you don't have the support people that are there to help you stay committed, you can change your mind. So we need to remember, when we're talking and giving education, it's not just to the woman, but also people who are going to be helping her. While we know breastfeeding is the preferred infant feeding method, there are some instances in which a woman cannot, or definitely should not, breastfeed. Galactosemia, that's a condition in which the body can't process galactose, sugar. The main dietary source of galactose is lactose, which is the natural sugar in milk and other dairy products. After milk is ingested, an enzyme breaks the lactose down into glucose and galactose. So the baby that has galactosemia has this condition and shouldn't receive breast milk. Okay. Any medication that crosses into the breast milk that can go to the baby obviously would be an issue. There are some things that we don't want them to have, such as street drugs and other addictive medications. If mom is undergoing chemo or undergoing a diagnostic procedure in which she maybe receives radioactive isotopes, any of those situations, she shouldn't be breastfeeding. Here in the States, we don't want infants of HIV positive mothers to breastfeed. However, I have seen in literature that, especially in your underdeveloped or third world countries, that it may be a better practice in the long run to allow an infant to breastfeed from an HIV positive mother than not, because without even that and the associated risk, the mortality rates were just too high. In the 70s, formula was all the rage because it had to be bought. If you could afford to buy formula, you were considered well off. Therefore, breastfeeding moms were looked down on as, less fortunate or poor, and weren't able to provide the best for their baby because they couldn't buy the formula. That practice set the stage for a generational belief or practice that supported formula feeding as opposed to breastfeeding, and the older maternal figures would promote using the bottle and formula feeding over breastfeeding. My mom formula fed Cecil, my brother. I was 8, so I remember it well. I chose to breastfeed Rachel because I felt that was best. My sister chose to formula feed. So, mom, her opinion was formula. That was what she, advocated for and supported. In other cultures, other ethnicities, think about your Latina population. Remember, they don't believe in giving the colostrum. They feel the colostrum is dirty. So unless they pump and dump to keep a supply and demand initiated and going, they may not make milk very well in the beginning. So they may choose to combine formula with breastfeeding, especially in those early days, which again will negatively impact breast milk production because you don't have that supply and demand. On the other side of the coin, your Muslim culture are very much advocate for breastfeeding, and they will continue to breastfeed for 24 months. Now, in the hospital, you may not see that done openly or well or even comfortably because of the modesty of the Muslim culture, but they are very, very much supportive and into doing the breastfeeding. Breast milk contains about 87% water, which is more than enough to meet fluid demands of the infant. So no supplementation really of any kind, water, juice, anything is necessary for the baby. Breast milk's all they need. Ultimately, if you give a baby any other fluid, even something as simple as water, if you're afraid that they're getting dehydrated, you actually negatively affect its nutritional status. If the baby receives water, it has no calories at all, so you're losing that. Plus, the baby's going to lose the urge to feed because there is something in its tummy taking up space. So it's going to lose an urge to feed, and then it's going to lose the calories from the negativity in the water, so you're actually going to hurt the baby. Your result, calorie deficit, growth restriction. Now, in the first 3 months, babies will need about 110 kilocalories per kilogram per day. Breast milk gives about 20 kilocalories an ounce, with the majority of the calories there being attributed to fat composition of the milk. Formula companies are actually structuring their formulas to have that same balance with the fat composition and the calorie weight. So if you look on the label, many of your formulas now are created to provide 20 kilocalories an ounce the same way breast milk does. When you're thinking about the newborn, remember they only have a small amount of glycogen stored, so there needs to be consumption with at least 40 to 50% of its total diet as carbohydrates. Lactose is the primary carbohydrate in breast milk, and it is the most abundant carbohydrate in the diet for up to the first 6 months. For your neurodevelopment and growth, fatty acids such as your ARA and DHA, linoleic and linolenic acids, they're essential. They're present in breast milk, and they are being added to formula. Remember how I said formula companies were making their caloric structure the same way breast milk is? Well, when they're looking at the essential fatty acids, they are making those mirror what breast milk is as well. Breast milk has all of the vitamins required for your infant nutrition. Now, if you looking in cow's milk, vitamins C, E, and D must be added in. So if you're getting breast milk, you're giving the infant what they need. When you switch over to cow's milk, then you're going to need to be adding into the vitamins. If you'll stop and think about, most of your your milk cartons will say that they are fortified with vitamin D, and that's because, especially whole milk in the infants, they're needing that extra vitamin. Vitamin D requirements for our infants are about 400 international units a day. So what makes lactation work? Well, first of all, you kind of got to start with where is it processed, where does it come from? Quick review of the anatomy. The breast is comprised of about 15 to 20 lobes, in which the alveoli of the lobes form the milk. Milk ducts will carry the milk from the alveoli to the nipple. The nipple has about 15 to 20 pores through which the breast milk will be expressed. It's important to remember it is not the size or the shape of a breast that determines if a woman will be successful breastfeeding. There are going to be other things that come into consideration, but the size and the shape of the breast is not part of it. Lactogenesis is the onset of milk secretion and includes all of the changes in the mammary epithelium necessary to go from the undifferentiated mammary gland in early pregnancy to full lactation sometime after parturition or having the baby, giving birth. How does this happen? Well, prolactin prepares the breast for making and secreting milk. It starts in pregnancy, reaches its peak prolactin-wise about 10 days after delivery, and then will begin to decrease. However, the prolactin levels will always be above baseline as long as the woman is feeding. Making breast milk is resultant of supply and demand. If the baby nurses and stimulates the nipple and removes the breast milk, prolactin is triggered to produce more breast milk. It's important to note that a breastfed breast never completely empties out. The alveoli are always producing milk, so there's always going to be something there. However, relative emptying occurs when the baby feeds. We tell the woman to keep the baby on breast and make sure that she empties the breast, but it's just never 100% by the definition completely empty. Now, oxytocin comes into play as the letdown trigger. When the nipple is stimulated, the posterior pituitary produces oxytocin and the milk ejection reflex, or the MER, occurs. A nipple has to be erect in order for the baby to latch on. So if a woman has inverted nipples or flat nipples, a breast shield may be utilized to put over the nipple, and then it will kind of help evert the nipple to help it stick out and provide support for the nipple as the baby is feeding. Around 16 to 18 weeks in the pregnancy, breasts will begin preparing for breastfeeding by producing colostrum. Now remember, we talked about colostrum when we were talking about our baby. It's that clear to yellowish fluid that the baby receives in the first 2 or 3 days of life. We call it the liquid gold. More concentrated than mature milk and very rich in immunoglobulin, less fatty than the mature milk though. Lactogenesis 2 is when the woman's milk comes in. Okay, so lactogenesis 1 is the colostrum. Lactogenesis 2 is the milk. Okay, milk comes in typically 3 to 5 days after the baby is born. The way that I remember it, kind of like the sensation, the breast just all of a sudden will fill up with milk. It's kind of like a full warm sensation, tingling in the nipple, can actually be followed by an involuntary letdown and leakage. So a good teaching thing is to make sure the woman has breast shields in her bra, because you never know when it's going to happen. So somewhere starting around day 3, she should probably be prepared, because otherwise she may very well stain or at least soak through her bra and her shirt. Out of feeding, the milk comes out in 2 stages. You have the first part of the feeding is fore milk, and then the second part of the feeding is hind milk. The fore milk is designed to slake the baby's thirst, because you got to remember this is food and water. So fore milk is thinner, kind of more like skim milk initially, and it's going to progress to thicker, richer, kind of fattier whole milk. Okay, so if you think about the differences in what skim milk looks like versus whole milk, but you're going to get the water, the lactose, and the protein initially in that fore milk. Okay, once the baby's nursed for about 10 minutes, then the fore milk transitions to hind milk, and hind milk is like the cream. Okay, so if you could ever seen even images of cow's milk, you know it's got the milk layer and then on the top it's got that thick, dense cream. That's what your hind milk is. It is very dense and fatty, and the hind milk is what optimizes growth and produces the sensation of satiety and contentment. So it's when they get this hind milk that they feel full. Because breast milk transitions as it's released, so remember I told you got to feed for about 10 minutes, and it's going to progress from skim milk to whole milk to cream, okay? So you need to remind the mom to keep the baby on the breast long enough to go through all the different levels and stages of the milk release. If the baby is only at the breast 10 minutes or less, it's lost out on that rich hind milk. So babies who don't stay on the breast long enough may not seem to grow as well, may seem like they are never satisfied because they're not getting that rich, dense hind milk from the last 10 minutes, 20 minutes of the feeding. In caring for the breastfeeding pair, being knowledgeable, supportive, and non-judgmental. Same way that you were doing to the woman all through pregnancy, that extends on after she has the baby. When you're taking care of the two of them together, you need to help her remain calm, especially if the baby is fussy and doesn't want to latch on. If the baby is rooting around, turning its face or its mouth into the breast, smacking its lips, sticking its tongue out, sucking on its fist, opening its mouth like a little bird that you imagine in the nest, all of those are cues that the baby's hungry and is ready to nurse. If your baby is agitated, crying, fussy, is it going to latch very well? Probably not. So if you've got, a mom sitting there trying to get the baby to latch and the baby is, rolling its head from side to side or maybe, waving its arms or kicking or something, maybe the baby needs to be calmed down first, because if the baby's agitated, it's not going to do what it needs to. You want to make sure mom is calm, because what she's feeling could be transferred or picked up. If baby's agitated, that's going to agitate her because she thinks she's doing something wrong. If she's agitated, baby's going to sense that, and baby may get agitated and not want to latch. So you got to make sure both parties are calm and ready to do this. And if one or the other can't settle down, then just stop for a minute and then start over. So here what we're looking at is latching on. To get a baby to latch, the woman will actually tickle the baby's lower lip with her nipple, and that's going to cause the baby's mouth to open up. With the mouth wide open, you want to quickly bring the baby to the breast and put the mouth on the nipple. Now the baby should take the nipple into his mouth, and he's going to then close down around it. All of the nipple and at least most, if not all, of the areola should be inside the baby's mouth if you're going to have an effective latch and optimal suckling. The number one cause of nipple pain or pain with breastfeeding is an improper latch with our baby. You need to make sure when the baby's on that you are listening to the baby and you're watching as the baby nurses. You want to be able to hear that breathe, suck, swallow cadence. The cheeks should appear rounded, not sunken in, and you're going to notice the jaw is gliding smoothly with the suckling. So as that tongue kind of comes under the nipple and pulls back, milking the breast, then you should see that jaw motion. If you look on page 540 in your book, you're going to see 4 different positions for breastfeeding. The football clutch is a comfortable position for the mom who may be nursing twins in tandem, so at the same time, because she can have a baby on each breast, and the babies are actually laying along each side of her body. Kind of like a football player tucks a football into its side and supports it in its arm and runs, then the football clutch does that for a mom. So it's really good if she's trying to do 2 babies at once. The modified cradle positions the baby across mom's lap, whereas the traditional cradle is the mom holding the baby up against her body as if she were cradling her. And it's the traditional cradle that I see a lot of women using if they are just holding the baby. But if they are using a boppy, one of those pillows, then the modified cradle seems to work well with that. The sideline position is a little bit more challenging because you have to balance yourself on your side, and some women have an issue with the superior breast maybe falling forward and obstructing their view of the baby. And there's always the potential that mom could fall asleep while the baby's nursing and somehow know that the baby gets injured. Now, it doesn't matter which position you use. With all of them, you want to maintain a sense of calmness, and whenever possible, you want to bring the baby into as much contact with your body as you can. If you need to reposition or change breast because we want to nurse off of both sides, don't just pull the baby off the breast. Just thinking, okay, well, I'll just pull it, because the baby is suctioned on there, and if you just pull the baby off, it's going to give a serious tug on the nipple and can actually cause some pain. So the proper way to remove the baby from the breast is to insert a finger into the baby's mouth. That breaks the suction hold that the baby has on the nipple. And you need to hold the finger in place until the nipple is completely free of the baby's mouth. All mothers should be instructed on the process of hand expression because not everyone will have access to a pump all of the time. And if she's separated from the baby and she misses a feeding, she may need to release some of the milk that she didn't express during nursing. Well, first rule, as with everything, is you need to wash your hands, okay? Then the woman is going to form a C, kind of like the letter C with her thumb and her fingers. And she's going to place her hand on the breast with the thumb kind of like at 12 o'clock and the fingers at 6 o'clock. She's going to place it on the breast just behind the areola, and then she's going to push the breast back towards the chest wall. And then she's going to kind of squeeze her fingers together, and as she's squeezing, she's going to roll her hand forward, and then that is going to squeeze the breast and the areola. She'll do this 2 or 3 times to get the breast milk flowing from the nipple. She needs to make sure that she rotates the hand around the breast, because she's got to make contact with all 15 to 20 lobes that are in there, so if she wants to completely express the breast. She needs to be careful that she doesn't pinch the nipple and that her fingers don't slide completely off the breast when she's doing the milking moves. It is now regulatory that women who breastfeed be given the opportunity to pump while they're at work. Portable electric pumps are used by a lot of women nowadays, and they make the process of milk expression much quicker than using the manual pump or even pumping by hand. However, it is mechanical, and electric pumps can sometimes be difficult to get the milk moving initially because it is a technology kind of thing. It's not the actual baby. Whether you're doing hand expression, manual pump, electric pump, anything artificial, something that you can tell mom to do to kind of help get the milk flowing is to have a piece of clothing or a blanket, something that smells like the baby. And as she's getting ready to start pumping, have her smell that. And the scent that she's going to have will actually work to help trigger a letdown response just by smelling that, because she can close her eyes and almost imagine the baby is there. Now, breast milk can be stored in different ways for different lengths of time. At room temperature, milk is good for 7 to just about 8 hours for a healthy baby. You don't want to leave it out at room temperature much more than 3.5 hours for a hospitalized baby. Milk can be refrigerated 5 to 8 days for the healthy baby, but you want to use it in less than 8 days for the hospitalized infant. If you have a fridge that has one door that covers a freezer and a refrigerator. So kind of think the dorm units, okay, or like hotel mini fridges where you've got a cold space and then this little shelf that's the quote unquote freezer unit. Well, if the fridge has one door like that, your babies who are healthy, their milk can be stored in that upper freezer component for 2 weeks. However, if you've got a hospitalized, a not as healthy baby, it is not recommended to freeze milk for these infants in that manner, okay? If you've got a traditional two-door unit though, so the freezer is a separate compartment to itself. The temperature is self-contained, self-regulated, away from or separate from the refrigerator, then milk for the healthy infant can be stored up to 6 months in a refrigerator freezer that's separate. And if you have a hospitalized infant, you can store milk frozen for 3 months. If the milk is stored in a deep freeze, whether it's a stand-up deep freeze or a chest deep freeze, it is good for 12 months for the healthy or 6 months for the hospitalized infant. Now, the decision to wean your baby is going to be individual, and the weaning can be done gradually, which may very well be easier on the mom in the sense of engorgement should be less likely. She can just, skip a feeding, maybe not feed at night as much, drop a feeding off every other day until she gradually, she's going to be decreasing the demand, so the supply should go down. However, there are some moms who are just like, okay, I'm done, that's it, and they will just suddenly stop. Those women are more likely to experience breast engorgement, however. If the woman experiences engorgement, remember, like we told the woman who didn't want to breastfeed, you want them to wear a supportive bra. They can use mild analgesics. They can apply ice packs to the breast or cold cabbage leaves. While pumping to relieve the pressure with engorgement isn't recommended, the woman who has been breastfeeding, she may express small amounts of milk just to kind of relieve that pressure a little bit, okay? This is not, you don't want to do that if you're not breastfeeding at all, but if you're weaning off and you've got the engorgement, you can do that for a little bit. Now, banked milk will be stored frozen until it is needed. Then when it's needed, it will be heat processed, making sure to kill pathogens and make it safe for consumption by other humans. Banked milk is only available by prescription. You can't just ask for it and you can't just go buy it. You have to have a prescription for it. And there is a per ounce fee that is charged for the breast milk to cover the processing. The organization that governs the Human Milk Bank is the Human Milk Banking Association of North America. And while they do collect a fee for processing, they do not pay donors for the milk. It is donated, so the people who give it don't get anything for it other than the satisfaction and gratification of knowing that they may have helped somebody. Breastfeeding moms will need to maintain a healthy diet that contains anywhere from 200 to 500 extra calories over her pre-pregnant weight. Now, if you stop and think about when she was pregnant, we told her just on average 300 calories a day was enough to maintain her and the baby for gestation. Well, if she's going to be lactating, she doesn't get to add on an extra 500 calories to that 300. That would be too much, okay? So I usually will tell women, especially if their weight was good and managed through the pregnancy, to just keep doing what they were doing while they're breastfeeding as well. But to get specific, a lactating woman is going to need about 2,700 kilocalories the first 6 months, and a little more than that 2768 for the next 6 months. So, we tell women just, traditionally 1,200, 1,500 calories, unless you're really into exercise and all that. That's what most women will need. So we're telling a lactating woman 2,700 calories. I mean, that's a lot of calories. But even with the increased calorie consumption, breastfeeding women tend to lose their pregnancy weight faster than women who formula feed and don't have that extra calorie increase. Now, we don't want moms to intentionally lose weight while they're breastfeeding. So you want to make sure you caution them against dieting or taking any medicines that's going to promote weight loss. A mom will need to rest as much as possible, especially early on when she's trying to establish a feeding pattern, because being fatigued and being stressed will negatively impact your milk production. It's not altogether uncommon for women to experience a sexual sensation with nursing, and if they don't know about it, if they haven't talked to anybody about it, it can be embarrassing to them because they think that there's something wrong with them, and they may even stop breastfeeding altogether. It's important they understand that this is in no way sensual. I mean, so if you feel something, it's not that you're getting your kicks from it, okay? You're triggering the release of oxytocin with the nipple stimulation. Remember, we said oxytocin's a love hormone, okay? It's associated with orgasms. So you may have some of those sexual sensations, but it is not sexual in nature. All right. So it's very important that they understand the difference in that and don't get freaked out and don't let that be a reason to quit breastfeeding. Breastfeeding women shouldn't be taking in estrogen when they're breastfeeding, so any contraception that they use needs to be a progestin-only contraception, or it needs to be completely hormone-free. No combined contraceptives for the breastfeeding woman. Also, any medicines that she takes in, really they should be cleared as safe and approved lactation medicines, and the pediatrician a lot of times will be able to tell her that. Well, we've talked about engorgement, and we need to remember that any mother is at risk for breast engorgement in the very beginning, okay? So whether you're breastfeeding or not, in the hospital especially, it's important to give the moms education about engorgement, because any mom is at risk for that to begin with. We said that the number one cause of sore nipples is a poor latch. However, there may be other things besides that can cause sore nipples. When you're thinking about nipples in general, I can remember people saying, oh, well, you have to rough them up with a washcloth, and you have to, get them ready for breastfeeding and toughen them up. Well, there's no need to prepare nipples by doing any of those things, okay? Nipple care is simple. You're going to wash the nipples with plain water. You really would like to let them just air dry. And if you need to, you can express a few drops of breast milk and rub that onto the nipple and the areola as a protectant. Now, if the baby gets a yeast infection in the mouth, we call that thrush. Mom can also get yeast infections there at the nipples, and that's really an uncomfortable experience. She will have things like sharp nipple pain, redness, the nipples may be scaly or flaky. It's going to be very uncomfortable to breastfeed. So it will need to be treated, and moms and babies need to be treated simultaneously. I mean, for obvious reasons, right? Because you don't want to keep passing it back and forth. So even if you examine mom, and mom is, diagnosed with having yeast infection, but the baby looks okay, you still treat the baby anyway. Um, Mom's going to be treated with topical antifungal creams and possibly a systemic antifungal if it is a severe infection, one that's just doesn't want to seem to clear up with a topical. The pediatrician will prescribe an oral antifungal for the baby. Both mom and baby's treatments should continue for at least 7 days after symptoms begin to improve. So it's not just a 7-day treatment and you're done. You have to continue on even after things start looking better. Now, a plugged duct will be identifiable because it will have a small white pearl on the tip of a nipple. That is a very classic sign. You want to remember that plugged milk ducts will have small white pearls on the tip of the nipple. Mastitis is an infection and inflammation of the breast. Now, classic symptoms for mastitis will be flu-like with achiness and fever, and there will be a characteristic pie wedge of redness on the breast. So just like plugged milk ducts have small white pearls, mastitis has a pie wedge of redness. Okay? With mastitis, you are going to treat it with antibiotics. The mother is to continue breastfeeding from both breasts as frequently as she can tolerate, or at the very least to pump the breast and keep working supply and demand. So a woman with mastitis does not stop breastfeeding. She is encouraged to continue breastfeeding. That is a very important point to remember. So we talked about cabbage leaves earlier as one of the things that can be done to relieve engorgement. So this is an example of a woman that is using chilled cabbage leaves to help with the engorgement. While we're not really 100% clear as to why the cabbage leaves work, the theory is that the sulfur content helps to reduce the inflammation and the swelling in the breast tissue. Your cabbage leaves should be chilled, and once the leaves become warmed or start wilting, you need to replace them with fresh ones. Now, pretty much this entire chapter has been about breastfeeding, but it's very important that you are able to speak to formula feeding because not all moms are going to choose to breastfeed. Okay, remember this is supposed to be a non-judgmental, fully informational concept, so you need to have good information on both sides of the spectrum. It's important to know that there are different types of formula and what is going to be best for the baby. There's your cow's milk based formulas, just kind of the standard straight up. Soy based formulas were devised for babies that couldn't tolerate lactose or the cow's milk protein. Your casein or hydrolysate products are for the babies who can't tolerate the cow's milk or the soy-based formulas. And then your fourth category is amino acid formulas. These are used in infants that have multiple food protein intolerances. Feeding readiness is determined by stable vital signs when the baby is born, effective breathing, and active bowel sounds. So if we're going to give formula, those are things that we need to have ready, because if your baby isn't breathing well, if they can't stabilize their own vitals, they don't need to be wasting the energy with sucking a bottle. All right. In the first 1 to 2 days, it's going to be typical for a formula fed infant to take in 10 to 15 milliliters at a feeding. The formula fed newborn will eat about every 3 to 4 hours, and by 3 to 4 weeks should have developed a pretty consistent feeding schedule. Your formula fed baby will need 6 to 8 feedings in an hour, and you got to think about your breastfed baby was feeding along those same lines. Now, prepping formula really takes a lot more than just putting a scoop of powder in a bottle and filling it up with hot water. And I know you know that, but there are some very specific things that you need to be able to remember and relay to your parent when you're giving them information about formula feeding. And one of the biggest things is to check the expiration on the formula, because formula can go bad. So you don't want to give your baby something that could make it sick. And you want to make sure that you're using the correct ratio of water to formula mix. Don't try and make the formula mix last longer by diluting it with too much water. And don't think that, okay, well, if I make it a little thicker, then it'll hold them a little more. It'll satisfy. You need to follow the instructions exactly the way they are given on the container. Just because there's a lot of things that go into it, I want you to read the teaching guidelines for formula prep that's on page 557. Look at these storage instructions for your formula and be familiar with that as well. And that's kind of it for newborn feeding. Because the American Academy of Pediatrics has so strongly said that for the first 6 months of newborn life, exclusive breast milk feeding is all that's required, a lot of education is now focused on the promotion of breastfeeding. But it's still important to remember that it is the baby's mother and her support person that are making these decisions. If they choose to formula feed, then we need to make sure that we give them just as strong a support, as much information as is possible, and that we remain judgmental, because she's the one that's going to be taking the baby home and doing this, feeding it, caring for it. We need to make sure that we are helping her and that baby by strongly supporting her decision as well. So that's it for Chapter 18, and I will see y'all in class on Monday.